So you're probably wondering about this title. And I think much that we do in healthcare involves a level of emotional intelligence, not just the kind of intelligence we usually think about. And I'm going to give you a number of real cases throughout this, and you don't have these actual cases in your handouts because I didn't want to blow the punchlines. And I think you're all probably pretty obsessive people, or you wouldn't be here today. That's actually a good thing. You all would have read ahead, and that would have kind of stolen the thunder. So that's my support. And you know, you've heard a lot this morning about screening, and Katie alluded to this quite a bit, and it is still, for me, you're going to hear my editorial comment here, it is still controversial. And the reason it's controversial is because we have not developed the evidence to tell us whether a screening program is helpful or harmful, quote unquote. And the U.S. Preventive Task Force, Malaz Bustani, who's a dear friend of mine, wrote this very impactful paper on this as he led that commission, and they didn't recommend screening. But that didn't mean that you couldn't screen. And a lot of people took that as we should not be screening. And what that report also said was you can't screen, but if somebody says that they have memory impairment, you should assess that further. And so I, in kind of my snarky way, would say, so if I can't ask them if they're concerned about their memory, because isn't that screening too? So it gets a little bit crazy. And I will tell you, though I am embargoed from telling you the results, there has been a large randomized trial that should be coming out in the next 6 to 12 months that hopefully will give us some of the first evidence on this. And you didn't hear me say this, but I think we'll be able to move on. The annual wellness visit does include cognitive assessment, but surprise, it doesn't really tell us how to do it. It doesn't tell us when to do it, why to do it, other than that you should do it. And it doesn't tell us, even more importantly, I think, how to talk about it. Because I think much about what we do as practitioners is about our relationships with our patients, at least as much about what we know, and our relationships then inform us about how we talk to our patients and what kind of words we use. And although I do use the word dementia with my patients, I do use the word Alzheimer's disease, and I'll tell you more about why I do that. I don't want to start there. I want to start where they are. Dave Rubin talked about, I love that quote, you know, playing where the ball lies. He's a golfer, and that was a golf quote. And it really is true. If you pick up the ball, that's a penalty. You get a penalty stroke. You move it somewhere else. And if you do the same thing with your patients, that's a penalty too. You really need to start where your patients are at. And if you're going to talk about this with people, and if you're going to identify problems, you damn well better be ready to act with something else. That's absolutely critical. And I think much about what you all are doing here today and what we're doing here today is to provide some of those concrete actions. So this is actually an old story for me, and I was actually at the time a mentee of Dr. Rubin's, and I conducted this study, and unfortunately you heard from our, I think, incredibly courageous Mr. Christensen earlier. This is sadly still a very significant problem. And we looked at this question years ago now and asked, you know, we knew already that physicians weren't recording these diagnoses in the medical record, but I said, you know, maybe they actually know it and they're afraid, either for medical legal reasons or they didn't, you know, for insurance reasons, maybe patients were asking them, don't put that on my record. So we actually asked a number of doctors in a very large health system here in Southern California, and this was, their patients had already been participating in a large study where they were well characterized. Some had dementia, some had no dementia. And we asked those physicians to estimate the cognitive functioning of those patients. And they all got patients that obviously had been in their practice. And one of the criteria of this was that physicians had to be with these patients for a minimum of 8 years. So they knew these patients. And these patients had this, what I've put here is a 2-stage dementia assessment that's now been fairly well validated. We also looked at medical records, but what I'm really interested in is reporting on what physicians told us in these surveys. We put a ruler in the survey very much like the one you see here, and all that a physician had to do was to place an X anywhere off of that 0, and they got credit for the most severely demented patient in their practice who was in this study, if in fact that's what they had and that's what the doctor said. So a lot of leeway, a lot of conservative approach here. And this is what they said. So for those who had, in the middle bars, the study was those who were what we knew about these folks being well characterized, and the yellow bars were what the physicians told us in the survey. And even in the middle group, these are very conservative criteria. So in the middle group, those are people who were classified as having dementia, and they were all moderately to severely impaired. And 20% of physicians placed that X on a 0, saying they were cognitively normal. Okay? Should surprise you a little bit. But even worse, those who had probable dementia, these were individuals who had mild to less moderate symptoms. A far fewer percentage of physicians identified those. And we've already heard firsthand about the benefits of an early diagnosis. What changes in your life when the symptoms, the struggles you're having, you now have an opportunity to get some help with. So can we move off of what other conversations we have and go into this space we might call cognition? And there's a number of questions that will come up. And for those of you who do direct patient care in the room, I'm sure you've had these questions for yourself. Are my patients fearful of this? Are they unaware? Do they not know? Do patients and families want to know if, in fact, I know? And what expectations about aging bias patients and families? One of my colleagues has done great work on patients' expectations about aging. You know, the best example is a patient walks into the office and they limp in, and I say, so it looks like you have some arthritis in your knee. He said, Doc, what do you expect? I'm 80 years old. Doesn't everybody have arthritis? The answer is no. And by virtue of thinking that everybody has this when I'm a certain age, it means that I shouldn't bother anybody about this. I really shouldn't. You know, doctor, I can't tell you, I'm telling you, you know, you're too busy. You have more important things to do. I don't want to bother you with this. So those expectations are really important. So if my agenda is around brain health, which it is, how do I make this patient-centered? And this is often a struggle for me. How do I play that ball where it lies? I'm going to give you some cases here, and I'm going to share with you what happened with these. And these are all real patients. This was a 93-year-old gentleman. This was just recent. This was in the past year. Came into our VA geriatric clinic. He came with his son. He had some hypertension. He had some obvious gait impairment when he walked in. He was now requiring some help with his instrumental activities of daily living. So he wasn't managing his own finances anymore, for example. And he was very social and very, very talkative. Talked about some current events. And I knew from the record that he'd had a mini mental state exam of 21 in the past. Abnormal score, maybe not for this individual, maybe sort of on the cusp. But because of who he was, I used another test, which is called the Montreal Cognitive Assessment Test, and that score was quite a bit lower. Now, it shouldn't surprise you, he didn't get a lot worse. In fact, that test was probing some of the things I was most concerned about that the mini mental state exam completely missed and always misses. So if you're using, just as a side comment, if you're using a test, please don't use the mini mental state exam. It's a lousy test. It was never designed as a cognitive screener. It was actually designed in the 60s to detect delirium on inpatients. But back in the day, it was the only thing we had. So it got picked up and used. And in fact, with this individual, because he had a lot of cardiovascular issues, I was more concerned about some of the cognitive problems he was going to have that I might not pick up on the MMSE, and in fact, I got a much lower score. But his son was sitting there, and his son actually sat there during the testing, and he chimed in very forcefully. My dad is great. He's great. He's doing great. And guess what? Honest, we deferred further discussion. But what happened there? I had the distinct impression on one side of my brain that I wasn't going to talk about this because this was going to cause trouble. And on the other side, I said, you know, we got to have this conversation. This is really important. So I'm telling you, true disclosure here, I fell into that trap of deferring because I didn't want to deal with the issue right then and there. And I was already 30 minutes behind. We've since had that conversation, and that's a much longer story. But I hope what I can do here is give you some examples about In fact, how we can have that conversation and how it can be a good conversation. We would work with different patient-family dyads in different ways because they all require different kinds of approaches. And I would argue that you need to practice this stuff. You need to think about what words you're going to use. You need to have a plan. And if you have those things you want to say that you know are said in a proper way, in a sensitive way, it's much easier to do that. If you have to start looking, you're already in trouble. So I'm going to talk about a number of examples, including how we initiate. This all plays directly into the KAER Toolkit, which I think Katie is to be congratulated on. Really a wonderful contribution for the field. I hope it continues to get out there because it needs to. We've talked about, what do you do when someone's saying, I'm doing great? No, he's not. And a patient who comes in and says, I'm worried about my memory. And then we need to do a lot of careful listening. It's back to what's my agenda, what's their agenda. I have to stop my brain, I have to stop my mouth, I have to be quiet. I forget what it is. I think a physician interrupts a patient well before a minute. I think it's something like 17 seconds into a conversation on average when we've looked at this in research settings. And we've got to be ready to acknowledge their concerns, not brush them off. Oh no, that's nothing. Everybody has a little bit of knee pain. When you get to be 85 years old, everybody has a little trouble with their memory. But we've also got to be good observers. We've got to identify it. We have to get our antenna up. We have to realize this is an important problem, and it's a highly prevalent problem, particularly for people like me who the average age of my patients is probably 83 or 84 years old. On a given day, I can see 10 people over the age of 90. That's not unusual anymore. So let me get into some cases, because I think this is, at least for me, where it gets interesting, and hopefully it will for you as well. So this was a number of years ago when I was in the UCLA clinic and had this just delightful patient who was 89 years old. Now, I want you to pay attention to this. She graduated Phi Beta Kappa from the University of Chicago. Now, just think about that for a minute. When that must have been and what kind of a woman this was. She was really smart and very articulate. And she had moved to LA about 6 years earlier. She was very active. She lived alone, and I had been taking care of her for a number of years, just like those doctors who were putting the X's on the rulers. And so she was also a very proud woman. She reminded me every visit that she had been to the University of Chicago and she had graduated Phi Beta Kappa. Just delightful. But this time she came in with her daughter. It was a routine visit, and she had had a several-year history of having some coronary disease. I had a little bit of concern about that. But she had lost about 7 pounds. So 7 pounds in 6 months, that should concern you a little bit. And I was a little bit concerned. And I was, moreover, even more concerned because this was the first time I was meeting her daughter. So that should say something to you as practitioners. Why is her daughter there? So in this case, she's there with her daughter. She's lost 7 pounds. She has these other risk factors. Aren't we beyond screening at this point? Now we're into case finding. Now we know we have a problem. I don't know that this is a cognitive problem, but I know there's something going on. And this is really, and for me, playing the ball where it lies, I wish David was here because he'd seen me reusing his quote many times, was the weight loss. So that's where I started. And for me, that was the red flag. And I wanted to know because the daughter was concerned. I didn't know yet what her concerns were. But why do you think you've lost weight? And note, the first person I asked the question to was the patient, not the daughter. It was really important. One of the things that I really emphasize with our trainees, our fellows, and our students is that whatever I do as a practitioner helps families see things sometimes in a little different way and helps them model their own behaviors. So if I elevate this patient as a very important, smart, capable person, that helps the family maybe see them in a different light as well. So that's really important. And so what did I say? Believe it or not, sometimes we forget to eat. So now I'm trying to transition a little bit into what I needed to do with this woman. And I'm already kicking myself because I'm really realizing, guess what? I haven't tested any cognitive function on her for at least a couple of years. Okay? So what did I use? I used the mini-cog. And I would argue even, despite the fact that Sue Borson is a dear friend who developed the mini-cog, if I'm going to reach for any tool with the least amount of time, this is the place I'm going to start. And I'm going to do that because not only does it give me a little bit of a window into someone's memory function, but it uses the clock draw. And I'll say a little more about that in a minute. So just the scoring that's in your handout, I'm not going to belabor this, but it's very simple. I like it because I can remember it, and I don't need to go looking for some pocket card to tell me how to do it. But the 3 words we use are important. You just can't make, I see people, they make up words, and it makes me so upset. That's not the right way to do this, because those words were actually clinically trial tested, and we know that those words matter. So you use the words that are provided. And so I asked her those 3 words, and then I had them repeat back, and I asked her to draw the clock. And so the clock, if either is normal or abnormal, the beauty of clock drawing in this case is that the instructions, when you go online and go and look up minicog, you can find the instructions there. It's either correct or it's incorrect. And we train college students, not even people who are in the medical fields, how to do this. We're doing screening now in our emergency department. Just in the last month, we've conducted over 300 screenings in people over 75 years old. And we see the clocks because they get uploaded into our RedCap tool, and we can see whether these students are actually scoring the clocks correctly, and they are. And that's basically the test. And the test, it turns out, performs very well, performs at least as well as some of the other instruments I've listed below. And the reason I like the clock draw is because it gives me a lot of information in one simple test. It tells me about people's visual spatial functioning, whether they can plan out something and do construction, and whether they can abstract, because remember, we have a specific time. If I say 10 minutes after 11, I have to be able to use my brain to know that there's no 10 that's actually after the 11. It's the 2 that means the 10. That's a form of abstraction. But it is dependent on some fine motor skills and having intact vision. There are some patients who won't be able to do that for those reasons. And there is a little bit of qualitative, i.e. some judgment in terms of, is this normal or abnormal clock? So this is her clock, okay? I didn't do this. This is what she did. I took a photo of this afterward. And, you might argue, well, all the numbers are there. There's a big space between the 12 and the 1. And, the anchors of the 3 is a little bit off. So it's not quite normal in terms of the number spacing. So something's up. And I said, now place the hands to show the time, 10 minutes after 11. When I show you this slide, you'll know why I almost fell out of my chair. Those are hands. She drew hands. So this is one of the most extreme examples of concrete thinking. This is a grossly abnormal clock draw. Okay? And I think she only got one out of 3 items on the memory testing. So this is an abnormal minicog, and I have concerns. So what do we do with this? I didn't do that very well, Dr. Chodosh. I'm really, she might have made some excuses, and I will say, many of my patients will have some difficulty with this. This isn't an easy test. And when you do cognitive testing, you actually want to start, and I didn't tell you that, but you actually want to start by telling people what you're going to do, why you're going to do it, and now you want to set this up. You want to say, I'm going to ask you some questions. Some of these questions may seem really easy to you. Subtext, I don't think you're an idiot. And some of these questions may be much more difficult. Subtext, if you get them wrong, you don't have to be embarrassed. And I can tell you in my now getting fairly lengthy career, I think I've only had one patient walk out after doing a cognitive test in all the cognitive tests I've done. But if I didn't employ that, I'd have many more. So we have to explain what this means. Making a clock requires a part of our brain that's in a different place where we remember some things. We have parts of our brain that we use for different things that we do in our thinking. And I like to use the word dementia, but I introduce it as a word. I don't introduce it as, you have dementia. I said, so let's talk. Have you ever heard of this word called dementia? This is a word that doctors use sometimes to describe certain clinical conditions. And we'll talk more about that. And one of the reasons I want to do that is I want to destigmatize this. I want to take some of the power out of these words because they're very powerful. And maybe for some people they're not powerful at all. Oh yeah, my dad had that, and but for other people it's life-shattering. And you want to explain, in very direct but simple terms what we're going to do next. Okay? So let me go to another patient that I saw. This was a patient that Dr. Harrell may remember, who's sitting in the audience, because this was one that we did through our telehealth program. And this was a guy that was still managing multiple apartments. His wife was very concerned. He was not. He had some peripheral vascular disease, he had some diabetes and some hypertension, the usual kinds of things that we would certainly see in the VA population. He was still driving. He had no reported car accidents and no tickets, because we always ask about that. And he was in what I would characterize as a traditional marital relationship, in that at least he thought he was in charge. And he was pretty domineering. So with this guy, do you want to approach cognitive screening? Do you want to go there? Are you feeling a little anxious about this? You should. So we have to find some different statements. Different statements will resonate for different people. So I want to link this process to something that they know, like a blood pressure cuff, using this for testing hypertension, or my stethoscope for listening to how his lungs sound. We want to know, how well our brains are working, so that we can make sure that we track this and we take good care of this. And if we identify some problem, maybe it's something that I did, maybe it's a medication I prescribed you, and now you come in and you know what, you didn't tell me, but your brain isn't working as well, and I think it's the drug. So I want to try to diffuse and normalize that a bit, but I also want to explore with them their concerns. What's their prior experience? Oh, some doc asked me to remember 3 things. Boy, he was a jerk. You'll hear that too. So I want to know about that, right? Because I need to work within that framework and that experience. And I want to be sure that I anchor this to the importance of this process and how it relates to both his safety and moving forward. And this very much ties into this issue of driving, which I know is incredibly difficult, especially if you live in Southern California. Not nearly as much, it turns out, if you live in Manhattan. But I will tell you that last week I was here for almost an entire week in LA, even went to the beach, and I didn't have a car, and I lived to tell about it. So there is now this wonderful light rail. Do you know anyone who has memory troubles? If they say yes, well, tell me more about that. I want to help them get into the context of this experience. And what do you think about the possibility in the future that you might have trouble with your thinking and memory? This was very much the kind of conversation that I had with this gentleman. And would you like to know about things you could do for yourself that might help keep your brain healthy? And his answer was yes. So the door was open for me now. And I said again, as I just said to you earlier, sometimes medications we prescribe or conditions that go untreated affect our thinking and memory. So a baseline measure is really important for us. This was a UCLA emeritus professor who, at the time, not that this is necessarily a lot, but he was publishing more papers than I was. And 2 years before, he flew to Brown to give a keynote symposium at the age of 91. So this guy was just lights out, extraordinary. But he had a chronic anxiety disorder. I've always said that anxiety disorder is what made him most successful, because it just drove him. And his wife had been diagnosed with cognitive impairment, and with mild cognitive impairment, he had been dealing with that. He was upset about it, but now he was concerned about his memory. And he had some pretty significant aortic stenosis. He actually ended up having one of those TAVR valve replacement procedures a year later. And he had some trouble with his legs. He was still running about a block. He'd run a block, he'd walk a block, he'd run a block, but he was still doing it. And here I have this guy, he's worried about his memory. What's the most important thing I want to do here? I want to do no harm. So what's happened to you that's led to your concern about this? Why are you worried about your memory? Tell me more about this. And what if we do a test, and in fact the test, you don't do very well on the test. You and I both know you're a pretty anxious guy, and when we do this test, you might not do so well on it. And what are you going to do with that information? And then I have to educate him a little bit. If I do this test, know that this is a screening test, right? This doesn't give me a diagnosis. And sometimes there are very capable people who don't do well on a test because they're nervous. So this is a good thing for us to do because we will both have an understanding if there's something we need to work on. So there again, this is really about the relationship. It's not about that neurologist who picked up the phone and said you had Alzheimer's disease. That's the antithesis of a relationship. This is about we're in this journey together, and that means the world to our patients. And I don't think I had more on that, but we did the test. Of course, it was normal. He was still concerned. And so what did I do at that point? I sent him to one of my favorite neuropsychologists, and so that he would be further tested and likely be reassured, which he was, because he was cognitively normal. So what strategies do we need to keep nearby? We've got to use not our IQ, but our emotional intelligence. And what do I mean by that? I mean, not only what do I see going on around in the room, but what am I feeling right now? And how do I take what I'm feeling to be not a distraction, but a strength? What is it telling me about what's going on in this room? If I'm feeling a little bit anxious about moving forward, what am I picking up in this other person? Because I don't always feel anxious going forward. So what is it about this situation? And I like very much to be very reflective and use the words us and we, not you and them. Okay? Gets back to that relationship, establishing trust, and more importantly, or as importantly, this sense of continuity. I'm in this journey with you. And I want to be sure that I identify what their strengths are, because those are our best allies, both the identification of those strengths, as well as that is uplifting for them, as well as my needing to know what those strengths are, because that helps me with the process going forward. And it really is about finding the half full cup, not about the half empty cup. Right? And I think that's very important. And all this discussion about dementia and all this about diagnosis and screening and all that, often denigrates into the half empty cup, not into the half full cup. And that's a problem that we have to work through. It's also a problem with what can be a very paternalistic healthcare system and very paternalistic providers, and we really have to fight ourselves, quite honestly, against those tendencies. Summarizing assessment. So the toolkit can really help us facilitate increasing this idea of cognitive health or cognitive assessment as being part of my usual clinical care. Now, in the case of our Phi Beta Kappa patient, I had to be nudged to pull it out of my pocket. So it wasn't a part of my routine, obviously. If it had been, we wouldn't be there, and I probably wouldn't be having this conversation, at least about her. So we've got to raise the topic. We've got to listen for and acknowledge what we hear. Too often patients will say, Doc, I'm having trouble, I'm forgetting things. Oh, well, okay, well, but are you taking your medications? And your blood pressure looks pretty good, and guess what I just did? I colluded to skirt by that. Now, it wasn't really a collusion because I think he was kind of ready to have a conversation because he brought it up, and I ignored it. So I call those Pandora box moments. It's sort of like, if I open this box, what's inside? And I may never get out of this office, so I think I'm not going to go there. And hopefully that becomes less and less for us as we do this more and more and become more comfortable with this. But we've got to build this into our usual healthcare routine. And I was telling somebody as a geriatrician, you talk about usual healthcare, being asked to create a geriatric practice. I won't even walk in the office if there's not a social worker there. I know that that's probably 60% of what I need to do. And I'm never going to get through the day. I'm never going to really be able to help my patients in the way I want to help them, and we're all going to leave frustrated. So that's where we really have to incorporate this into our usual healthcare routine. And I think for being champions, this has got to be really important that you emphasize not just the clinical work you need to do, but the psychosocial work you need to do, and how this needs to be embedded in your practice environment if you're going to be successful. And I think there is a return on investment for this. There's, in fact, a huge return on investment. There's, in fact, a huge return on investment. And part of the reason there's such a huge return on investment is because healthcare is so expensive, and acute healthcare is so expensive, that it won't take much to get under that bar and to show a positive return in cost savings. So, do we need to understand dementia subtypes? I mean, this is a rhetorical question, obviously, because I believe that we do, at least to some degree. And this is a list now from the new DSM-5. It's not so new anymore, actually. And some things have changed, which is in your handouts, and I won't spend much time highlighting that. But this is the DSM-5 neurocognitive criteria for neurocognitive disorder. One of the things you'll notice is they took the word dementia out of the page. It's not there. They talk about cognitive function and cognitive deficits, but they don't talk about dementia. They'll talk about major or minor neurocognitive disorder due to, and then you'll see it there. But I think this is useful. Having, if you have a sleep disorder, I suggest you put the DSM-5 by your bedside and you read it every night. It's better than any of those drugs you might be taking, which, by the way, might hurt your cognition. But this is actually a page that is very, and even the 4 and the 4R were very useful, because I use this for myself, and I use this as a teaching tool to help people make the diagnosis. And when I talk to large primary care physician groups, I really use this as my lever, because I do believe, as Katie has suggested, that about 75% of the patients who come into your office who have a cognitive disorder, you can make that diagnosis. Now, if we were really good, and if we were doing things I think in the right way, I'd probably have to lower that number quite a bit, because it would mean that people were getting detected earlier and better, and it wouldn't be as much, I don't really like the term, but as much low-hanging fruit, so to speak. Easy marks, people that, I can't tell you how many times someone will come in the office and we'll have the discussion, and it's really embarrassing. And they'll say, Dr. Chodosh, I've been to 5 physicians, and you're the first person who's willing to talk to us about this problem. I can't tell you how often that happens. It's very disconcerting. So let's talk about some of these cases. So this is a patient who's 79 years old, and he presented with some periods of confusion, and he'd had some visual hallucinations, and I'll say more about what those were. He'd had a history of gait impairment, and in fact, more recently, he'd been falling. He had good times and bad times, and today in the office, he was alert and oriented. He knew the month and the year, but he didn't know the exact date. How many times have you not known the exact date? Go on, admit it. Okay, that's why they're screening tests. So what other history exam features do you want to know? And I think we'll move through these. So this is to give you some guidance in terms of how you might approach this. So I had a number of questions about this. So tell me more about the images you see, and I'll tell you why in a minute I wanted to know specifically about the images. What are the circumstances of falling as a geriatrician? I need to know that. What are changes in thinking and memory, and do I want to look at his blood pressure? Do I want to do a physical exam? What are the other specific aspects? So this is what he described. I put a picture over the face, not being sure where this slide came from. Might be somebody I know. But he said very distinctly, there's a woman who stands in the corner, and she has on this polka dot dress, and she's looking at me. Now, he wasn't very worried about this, and he could describe her in very descriptive detail. That's important. We need to know that, okay? What are the circumstances of falling? Well, he didn't say this, but his family informant's a really bad word to use these days, isn't it? I'll use it anyway. Said he was more clumsy and tripping over things. And by the way, you need that other person in the room. There may be some things you want to do with someone by themselves, but you need that other person. When I have somebody who's over the age of 70 who comes to see me and they come by themselves, now I'm worried. I want those family members in the office. And so the memory was okay, she said, but sometimes he gets real confused and then he's better again. And what about his blood pressure? Well, laying down, he was a little bit hypertensive, but standing up, it was probably too low. And what about his physical exam? What specific aspects? Even before we talk about physical exams, anybody know what this is? Shout it out. Yeah, smart group. So he had, because I would give it away with this, he had these other Parkinsonian features. Some kind of very expressionless face. He had a little rest tremor. He had a little rigidity in tone. They don't always read the textbook. Okay? This guy had read the textbook. So this was a very classic case of Lewy body disease. And it is actually, because vascular dementia is not considered neurodegenerative, it is the second most common dementia. And he had all the classic symptoms. And on this slide, I won't go into detail, but you'll see the core features are having this spontaneous Parkinsonism that just came up. And axial means that if you take somebody and try to lift them, put your hands behind their head and lift them off the bed, move their head forward rather like that, the whole body comes up. It's not nearly as much rigidity in the arms, which is appendicular. They have lots of issues with paying attention. They look like delirious patients, and they often get misclassified as delirious patients. And this fluctuation in cognition is that kind of delirious kind of appearance. And those visual hallucinations are important. They're not auditory, they're visual, and they're almost always very, very detailed. There's a calico, he didn't just say a cat, there's a calico cat walking across the room. There's no cat in the house, but he thinks it is. And very often these are not terrifying or troublesome to them, they just see it as just there. And even sometimes they'll say, Dr. Chodosh, I know you can't see her, but she's sitting right there right now. So it's that kind of experience. And just to, Parkinson's disease, if you live long enough with Parkinson's disease, you develop dementia. That's pretty well known. These are Parkinson's dementia and Lewy body are very similar in many ways. There's a lot of crossover. And those patients that you might see who come in and they come in with their wife and maybe she's got some facial bruises and you're wondering if there's domestic going on, or she's got arm or leg bruises and she's sleeping in a different bed now. That's because he's got a REM behavioral sleep disturbance, and in the middle of the night, when he goes into REM sleep, he might just throw his arm out like that, and people can get hurt. And that is an important. We don't ask about that often enough. So let me talk about a lawyer who I said fell from grace. Again, I want to emphasize these are real people. He was 81 years old. He was still practicing as an attorney. He was well respected among his peers, and he came to see me. He was concerned, and he was mad. We knew that he had missed appointments with his clients. His wife had told me this. His legal briefs had become less descriptive. He had gotten lost while driving home. Now, this was in LA, so maybe it's easy to get lost while driving home. But he had been given more menial tasks at work. He'd really been in many ways professionally ostracized. And he wasn't included in a lot of staff discussions anymore. So again, what are the thinking and memory problems, and how long has this been a problem, and has it progressed? One of the benefits of continuity is I get to see people over time. And I have to tell you, sometimes on the first visit, and often on the first visit, I'm not sure. But the tincture of time is very important. And the other thing to note is that you've probably seen lots of discussion about Alzheimer's and related dementia biomarkers, and people with biomarkers, you usually think about CSF and neuroimaging and even plasma now, certain proteins that we're looking at. But this still remains a clinical diagnosis, period. It is a clinical diagnosis. We're not there yet. So we have to act clinically. Doesn't mean we don't look at other biomarkers, but we have to act clinically. So we have to ask these questions. And was there anybody else with similar difficulties? Well, he has trouble remembering things that we discussed, things we did yesterday, even today. How long has it been a problem, and has it progressed? It started a few years ago, I guess, but it's been getting worse. So now, even though I didn't have the benefit of that time period, I'm given the benefit by someone who I think is a reliable family informant. And what about other family members? I think he had an uncle and a few cousins, okay? Put neuroimaging with a question mark because it should be a question mark. It's almost never an absolute unless he has some obvious neurological findings. This is Alzheimer's disease. And this is what we usually think about when we think about dementia. Even though I will tell you that maybe in the next 5 years, we're going to have a different discussion, and that we're not going to be talking about Alzheimer's disease as such as being the predominant cause of cognitive deterioration. But it is quite insidious. It's most often with memory loss. You forget details of recent events. You have difficulty learning. You sometimes have trouble speaking. Visual, spatial, and executive dysfunction are common. And usually memory impairment and the difficulty naming things are the earliest symptoms. And there are these other variants that make it very difficult or more challenging. And I had a patient who came in my office one day, and I knew her well. She just wasn't talking right. could have had trouble understanding her. She seemed to be able to understand me pretty well, and we could sort of get through it, but at that point I wasn't really sure. And so at that point you should be asking, if you're thinking cognition, is this Alzheimer's? Is this frontotemporal dementia? Because it does can present with a language disorder, as can about 10%, I think, of Alzheimer's disease present with a language disorder. So this guy had a history of personality change. He was irritable, he was depressed, he had no empathy, he had no insight, and he refused medical care during that time period. And he too had been forced out of early retirement. He had progressive loss of language, he'd been diagnosed with early AD. Okay? Can't tell you how often that happens. Do you agree? You shouldn't. I didn't make this up. You can't make this stuff up. He starts eating hamburgers and ice cream exclusively. He never ate hamburgers in his life. And worse yet, now you start to get a picture of what it's like to live as a family member. And, our friend, Mr. Christensen, who was here earlier, talks about, loved ones. It's so true. He began frequently opening and closing the garage door in the middle of the night. And then finally, the jig was up. He was walking the dog 3 a.m. in the morning, totally naked. Okay, what do you think this is? Yeah, FTD, right? So the age of onset influences our diagnosis, right, and what's probable or possible. And having that informant is always important, as I've told you. You always want to assess for depression, and you want to get a psychiatric history, but I can tell you that these individuals often spend 3, 4, or more years with a psychiatrist before they come back to see us. Unfortunately so. And this is FTD. This is the third most common. We see it in kind of mostly in people in their 50s and 50 to 60 years old. You do see it over the age of 70, but it's a much smaller amount. He presented more with what we'd call behavioral variant, and it is very classic, that apathetic appearance, that lack of insight, lack of empathy. It can be absolutely astounding, and if you talk to them and if you cognitively test them, they look and they act cognitively normal otherwise. And there are different kinds of progressive aphasias. So the story gets even a little more interesting and challenging. He starts choking on his hamburgers and he starts only eating ice cream. And now he's losing weight. And now he's falling as well. He's got a gait abnormality. So what do you think? Well, we often forget this, but there is a benefit to a physical exam. I tell my medical students that. It's not all in the radiology suite. And he had bilateral foot drop. And when we took his clothes off, which you always need to do, he now had loss of muscle mass, and he had what we call fasciculations, little quivering of his muscles. What do you think's happened here? What is this? Okay. This is ALS. Wait a minute. He had FTD. What's he doing with ALS? But in fact, we see that a significant proportion of patients with FTD actually go on, or maybe sometimes start with motor neuron disease, and it's related to all these Parkinson's plus syndromes, and there is this protein. The reason I bring this up is because you're going to hear more about this protein, which is called TDP43, and this is kind of parenthetical to my comment about whether Alzheimer's is really going to be Alzheimer's, because there's a lot of new investigative work looking at this particular protein on scans, on autopsy material, so the world is changing rapidly. But for this patient, you want to consider genetic testing, because there is certain concern for first-degree relatives especially. So an 83-year-old postal worker, we're almost done, because I know I'm standing here between you and lunch. I'm acutely aware of that. Guy's a 3-year history of gait impairment. He was kicked out of his bridge club last year. Ever heard that story? That is so sad. Because he was too slow. It wasn't because he couldn't do it. They just kept waiting for him to get it together. And he was more forgetful, but he had compensates. We had lists and Post-it notes around the house. He sort of took my job away from me. I was going to tell him to do that. And he had diabetes, wasn't insulin dependent, and hypertension, and he was using his meds. He was doing everything right. So again, we go through these questions. So when did you first notice this? How have things changed? And I go back over this again and again and again, because I think if you're like me, you need repetition to learn something. And you need examples to model your own words, your own behaviors, the own things that you want to do. And why do I care about whether he can't remember something, but he could retrieve it if I give him clues? Well, because that's what we see in people who have more subcortical and frontal disease that it isn't necessarily that they can't remember something, it's that they can learn new things, but they have more trouble retrieving it. And now I know you're all worried about your own vascular dementia, right? Stop worrying. So, challenge with retrieval of information you already know is, we believe, to some degree, an age-related process, meaning that when you get to be my age, it gets to be a little more difficult to remember somebody's name that you knew, particularly if it's information that you haven't accessed for a very long time. And again, it's probably true that we've talked about these separately, but there's a pure Alzheimer's condition is actually pretty rare. And a pure vascular condition may be not quite as rare, but also relatively rare. So we see mostly what we call mixed dementias. But to parse this out this way, with vascular, we see things that might be really sudden in change, but it might also be quite insidious, like that Alzheimer's patient. And when you're testing, you know that you see this nonspecific testing, but you see sometimes trouble with attention, some trouble with planning, and particularly with processing speed, the ability to get something done cognitively that took them much less time in the past. And it's the second most common cause of early onset dementia, but remember, just for nomenclature, it's not listed as a neurodegenerative condition. So this looks easy, right? You're not saying yes. It's not, but you all can do it, and you can all do it with practice and thinking about this more structured approach, and particularly from an approach that's provided by the KAER tool. And in primary care settings, the majority, I gave you some very standard, straightforward cases and some unusual ones too, but this really does characterize the majority of presentations. If we don't gain objective data, we have no clarity. And so what we're doing with these investigations and these questions I asked and these simple tests that I've done, we're looking for objective data. And you know, there are about 25% right now we guesstimate who come in who are less typical, either where additional reassurance might be needed, like my 93-year-old physics professor, or where I need more referral, like somebody who comes in and they're 50 years old and they're clearly having some difficulty. I want some help with that, and I want some certainty with that. So to conclude, we're going to help people. It really doesn't matter, but it's so true for this condition. If we're going to help people who have problems, you first have to know the problem exists. So I think by now you can tell that I'm kind of an advocate for screening. And starting the conversation, which is the kickstart, is really necessary, but it's never sufficient. But we've got to start that because we don't even do that. And this does require both a multi-domain as well as an interdisciplinary approach, but it's best accomplished if I use my objective cognitive tests and I have my family members present that I can talk to. And you heard this alluded to by Dr. Rubin's talk. I am, for the most part, although we heard someone who got a lot of benefit from his 20 milligrams of Aricept, I think that's more, we hear that more commonly with a younger person, an early onset, but I am very much a medication therapeutic nihilist when it comes to this. I find, and it may just be my patient population, I stop these medications far more often than I prescribe them, due to weight loss and loss of appetite, due to sleep disturbance, due to, actually we don't think about this much, but due to incontinence. It's an under-recognized complication of acetylcholinesterase inhibitors. And more importantly than all of that, and I will certainly try these medications and we'll have very detailed conversations about them, educating patients, educating their families, making sure that we are psychosocially sensitive and appropriate is really the name of the game here, is really where we're going to get the maximal benefit and where we need to do most of our work first, now, and I would argue forever. Thank you.